outline of my talk will be introduction, then I'll talk about the different diagnostic categories of the Bethesda system, and then I'll have a few words of conclusion and then references. So as an introduction, an FNA of the thyroid plays an important role in deciding as to which nodules are being referred for surgery. 5 to 7% of the thyroid nodules are malignant, and screening is important in order to diagnose those malignant nodules. And then clinical history is very, very important. And from the clinical history, we are able to determine the risk of cancer in each and every individual. So these you can determine by looking at the rapid growth and maybe hoarseness of voice of the patient. And if the patient was exposed to radiation of the head and neck, or for the patients who are having cancers like leukemia, if they were exposed to whole body radiation. And you also try to exclude familial thyroid cancer, as those patients have a high risk of developing thyroid carcinoma. And also patients who are having thyroid syndromes, so like Peter-Namatas syndrome, or Cowden syndrome, Carney complex, Werner syndrome. So all those patients have a high risk of developing thyroid cancers. And usually the screening involves palpation, but then it's recommended that it's better to use ultrasound, because it increases the diagnostic yield of the lesions. And during ultrasound, it also helps you to do the thyroid score, which the clinicians do. So there they look at different factors to determine whether they are going to sample or do an FNA of the lesion. So they look at the composition of the lesion. Is it predominantly cystic or solid? And the echogenicity of the lesion, as to whether it's hyper-echoic or hypo-echoic, or it's a combination of the two. They also look at the presence of calcifications and the margins of the lesion, whether it's irregular or smooth. So there is some calculations that they do looking at those different parameters, and then they are able to decide whether they will biopsy the lesion or not. And also thyroid stimulating hormone, or TSH levels, are also important, because they help you to decide whether you will have to do a FNA or not. For example, if you have wart nodules, you avoid doing FNA, because most likely it is a Graves' disease or hyperthyroidism. And if the TSH is normal or high, so you assume it's a cold nodule, so you'll go on and do FNA. So as an introduction, clinical history is very, very important, and assessing the lesion. So this is just a micrograph showing an example of an ultrasound guided FNA. So we're able to see the tip of the needle within that solid nodule, which helps reduce results which are unsatisfactory or inadequate. And you are able to avoid things like blood vessels, which you can easily see on ultrasound. From my experience, where I was working at Inkosi Albert Lithuli, we used to have a multidisciplinary team whereby we're having radiologists, surgeons, technologists, and pathologists. So the radiologist will help us do the ultrasound, so we'll be able to visualize the lesion and then do the thyroid score here and there, and then we're able to see which lesions we're able to do the FNA, and then we'll do we'll quickly process the specimen here and there, stain it, and give them rapid results. So that used to help a lot with turnaround time and with decision making, and it helped a lot in reducing the number of inadequate specimens. So now I'm going to go through the 6 diagnostic categories that are there in the Bethesda system for reporting thyroid cytopathology. So we have 6 categories. The first one is non-diagnostic or unsatisfactory. The second one is benign lesion. The third one, you have atypia of undetermined significance or follicular lesion of undetermined significance. The fourth category is suspicious for follicular neoplasm or follicular neoplasm. And then in this category, you also have a Hethel cell neoplasm or suspicious for Hethel cell neoplasm. And then the 5th category is suspicious for malignancy. And the last and 6th category is malignancy. So from this table that is depicted here, you can see that from second and third column, we're able to appreciate that as you go higher in categories, even the risk of malignancy is higher. And then the last column just shows us the different management modalities that are used to manage these lesions. So this is category 1, which is non-diagnostic or unsatisfactory. So I'll first start by defining what I mean by adequacy. So you need 6 groups of benign follicular cells, and in each of those groups, you must have about 10 cells per group. And then there are some exceptions. If you have abundant colloid, we know that if you have abundant colloid in a thyroid lesion, it's benign. It's unlikely to be a malignant process. So if you have abundant colloid, you are able to make a diagnosis even if you have few follicular cells. And then if you have a specific diagnosis, like you have clear features of malignancy, or you have clear features of papillary thyroid carcinoma, that is an exception. Or any atypia that you see in a group, in any groups, even if they are not defined according to the definition of adequacy, you can still go ahead and make a calling. And then unsatisfactory, you can make that diagnosis if there's things like obscuring blood or overtly thick smears, scant cellularity. So in that case, you can go on and make the diagnosis of unsatisfactory. And then the second category is benign follicular nodule. And then this one, the criteria is that you predominantly have macro or large follicles, macro follicles, low to moderate cellularity. You have cohesive follicular cells, uniform, evenly spaced cells. So there shouldn't be crowding of cells, overlapping nuclei. So they should be uniform, evenly spaced cells. And then the chromatin of benign follicular cells is coarse. They shouldn't be clearing. Yeah. And then background colloid. And colloid, you usually have different, comes in different forms. It can be fluid, it can be thick colloid, which may even show cracks, and it might even be thick, looking like bubble gum. And then in the background, you may have Hethel cells, but Hethel cells shouldn't be the predominant cells, because that will lead you to other categories. So, but from my experience, in most of the benign follicular nodules, you will have some scattered Hethel cells. And then you may have admixed macrophages and cyst lining cells. And then this is just a description of colloid. Like I said, it can be viscous, shiny, and light yellow or even gold. It may have dark blue, violet, magenta, or pink, depending on the stain if Romanowski. And then it may look green to orange if it's pap stain. So this micrograph just shows a benign follicular nodule. So we have these large follicles which are of moderate cellularity, but then you have background colloid. And the cells within these follicles are uniformly spaced and they have this cos chromatin. So if you have this type of lesion, you can easily diagnose a benign follicular lesion. So this is a large follicle also consisting of uniformly arranged follicular cells with cos chromatin, background colloid. So you can easily make the diagnosis of benign follicular nodule. So this is just the high magnification of the previous slide. And then this slide just shows a thick colloid with some areas of cracking. And then this one, the colloid looks thin but and fluidy, but it's abundant. And if you look, we don't have that many groups of follicular cells, but this is enough for you to call it a benign follicular nodule. And then this is also fluidy colloid. This one, they say it might look like torn clothes, but in the background you can still see that liquid type of colloid. And then this is an example of how Hertel cells look like. So the cells are large, they contain abundant granular cytoplasm. The nuclei have these nucleoli, most of them. And then this example is just from the cells that are lining the cyst. So as you can see, at a glance, they look scary. But if you look, the cells still have a low nuclear to cytoplasmic ratio, although they look like they show reparative changes, because some look hyperchromatic and there is some pleomorphism. But this is what you see usually in the if you have aspirated the cells that are coming from cyst lining. And then still under category 2, we have chronic lymphocytic thyroiditis, or what we call Hashimoto thyroiditis. So here you will have mixed population of lymphocytes, and then you'll have tingible body macrophages, and then you'll have dendritic lymphocytic aggregates, and then you will also have Hertel cells admixed within the lymphocytes, and then you may have some follicular cells, benign follicular cells, and then scant colloid. So this micrograph just shows that a polymorphous population of lymphocytes. Yeah, in this micrograph, I'm not able to see any tingible body macrophages, which are macrophages which contain or have ingested some material within the cytoplasm. So this is just a Gimsa stain for the same lesion. And then this is what they call dendritic lymphocytic aggregate. So you have this aggregate of benign lymphocytes with admixed large cells, but the cells have smooth, regular contours, and then they also have some nucleoli. So these are what they call dendritic lymphocytic aggregates. So this is just the Giemsa stain. And then still under category 2, you have subacute or dequervance thyroiditis. So this one usually consists of lymphocytes with admixed multinucleated giant cells, and you may also have granulomas that are very rare within this lesion. So this is just an example of a multinucleated giant cell that you can see within this lesion. This is an aggregate of epithelial histiocytes, which we call a granuloma. So as you can see, the cells are more sort of spindle and epithelial histiocytes. So this is what we call a granuloma. So that was category 2. So before I go to the next category, with this granulomatous thyroiditis, it's important to exclude things like infectious diseases, especially tuberculosis, which is very, very common in our case. But with tuberculosis, usually you'll have background necrosis. But if we have this picture, we always do a Ziehl-Neelsen stain just to make sure that we are not caught out. And then the next category, which is category 3, is atypia of undetermined significance or follicular lesion of undetermined significance. So by definition, these are specimens that contain cells with architectural and or nuclear atypia that is not sufficient to be classified as follicular neoplasm or suspicious for malignancy or malignant, or if you have a compromised specimen. So the criteria is that you'll have a prominent population of microfollicles in an aspirate that does not otherwise fulfill the criteria for follicular neoplasm or suspicious of follicular neoplasm. And then if you have predominance of heddle cells in a sparsely cellular aspirate with scant colloid. Interpretation of follicular cell atypia is hindered by sample preparation artifacts. So if you have some artifacts that are hindering you from interpreting the cellular atypia, this is the category where you put it. Or cellular sample which composed virtually of exclusive population of heddle cells, yet the clinical setting suggests a benign heddle cell nodule, like lymphocytic thyroiditis or multinodular goiter. So in that case, you are going to put it under that atypia of undetermined significance or follicular lesion of undetermined significance. Or if you have focal features suggestive of papillary carcinoma in an otherwise benign appearing sample, like Hashimoto thyroiditis, abundant colloid, and benign appearing follicles, but you have focal features suggestive of papillary carcinoma, so you can put it in this category. And then there are some differential for that third category. As you can see that there is some, you are uncertain when you are making that diagnosis. So it is important to exclude them. And then the next category, which is category number 4, this one, it's a follicular neoplasm or suspicious for a follicular neoplasm. So this one, you'll have marked cellularity. So the specimens will be hypercellular, and they will predominantly have micro or small follicles, and you may also have trabeculae. So the cells will be enlarged and crowded follicular cells. You may have mild nuclear irregularity and pallor. You'll have scanty or no colloid. So this is an example, but then here the picture doesn't show the cellularity as it was zoomed in. So it will be hypercellular, and then you'll have these micro follicles, and then you have some nuclear overlap. And then this another example showing the micro follicles. And then within category 4, you also have Hethal cell neoplasm or suspicious for Hethal cell neoplasm. So this lesion will consist purely or exclusively of Hethal cell population, which will be non-cohesive cells with prominent nucleoli, and then you may have pseudosamoma bodies. So this is just an example of Hethal cell neoplasm or suspicious for Hethal cell neoplasm. So as opposed to Hashimoto's, because Hashimoto's thyroiditis come to the differential, Hashimoto's will have predominance of those reactive polymorphous population of lymphocytes, as I discussed, and then you'll have minimum representation of this kind of cells, Hethal cells. So these cells have abundant granular cytoplasm, and then they have these nuclei, which usually have prominent nucleoli. So the differential diagnosis, before I go to the next lesion for suspicious of follicular neoplasm or follicular neoplasm, are benign follicular nodule. So, but that one won't have the predominance of Hethal cells. As I said, in a benign follicular nodule, you may have scattered Hethal cells, but they are not the predominant cell type. And then papillary thyroid carcinoma, especially the oncocytic variant or Hethal cell variant, may look like this in some cases, but then what will help you there, you'll have a nuclear overlap, and then there will be nuclear features of papillary thyroid carcinoma. So you'll have nuclear pseudo-inclusions, you'll have nuclear grooves, and you'll have nuclear irregularity. So there should be features of nuclear features of papillary thyroid carcinoma for you to entertain that diagnosis. And then there is also a lesion that was described a few years ago, which is called NIFTP, NIFTP, which stands for non-invasive follicular thyroid neoplasm with papillary-like nuclear features. But this one will be very difficult to diagnose on fine needle aspiration because you need histology features to diagnose this one, because it must be well circumscribed or encapsulated, a very small proportion of papillae, and you shouldn't have necrosis, and you shouldn't have vascular or capsular invasion, which you cannot assess on fine needle aspiration. And then things like renal cell carcinoma, because as you can see, these cells, they are large, and some of them, they almost have distinct cell borders. So metastatic renal cell carcinoma may come to the differential diagnosis. And parathyroid lesions, because some of them, they do have oncocytic variants. So they also do come to the differential. So the fifth category is suspicious for malignancy. So here you have some features of malignancy which raise a strong suspicion for malignancy, but the findings are not sufficient for conclusive diagnosis. So here it depends on the lesion that you are suspecting. Like if you are saying suspicious for papillary thyroid carcinoma, so here they have two patterns, pattern A and pattern B. Pattern A is where you have patchy nuclear changes And pattern B is where you just have insufficient nuclear changes. So for pattern A, there are cellular. So here you already have a lesion which is like a follicular neoplasm or suspicious of follicular neoplasm, but then you also have features that make you to suspect papillary thyroid carcinoma. So there will be hypercellular, and then you'll have benign follicular cells mixed with cells that have nuclear enlargement, nuclear pallor, grooves, irregularity, and molding. And then intranuclear pseudo-inclusions are absent in this lesion. And then the pattern B, where you have incomplete nuclear changes pattern. So there will also be hypercellular, mild to moderate nuclear enlargement with mild nuclear pallor. Nuclear grooves are evident, but then the other features are usually minimal or absent. So here you'll have predominance of nuclear grooves, but then the nuclear irregularity, molding is very minimal or absent. And then intranuclear pseudo-inclusions are very rare or absent. So this is just an example where you have some nuclear grooves, but then and then nuclear pallor, but then some of these cells have coarse chromatin. And then this is another example where you just have some nuclear grooves here and there, but then the rest of the cells still have this coarse chromatin. And then this another example showing similar features. And then category number 6 is malignant, which includes various lesions malignant lesions that you can find in the thyroid. The first one, we have papillary thyroid carcinoma, or what we call PTC. You can have primary lymphoma of the thyroid. We have poorly differentiated thyroid carcinoma. We have medullary thyroid carcinoma. We have anaplastic thyroid carcinoma. You may even have metastatic carcinomas like squamous cell carcinomas, metastasizing to the thyroid. So starting with papillary thyroid carcinoma, this is a malignant epithelial tumor derived from thyroid follicular epithelium, and it displays characteristic nuclear alterations or nuclear features. You may have papillary architecture, but that is not a prerequisite. So what is important, you must have nuclear features of papillary carcinoma. So the cytomorphology, you have sheets, or you may have cellular aggregates or shells of cells. You may have papillae, like I said, which are not a prerequisite, microfollicles. And then the nuclear changes that I'm talking about, you'll have powdery, chromatin, nuclear grooves, nuclear pseudo-inclusions. You may have nucleoli, and then membrane thickening and irregularity. And then you have nuclear crowding and molding. And then the cytoplasm is variable. It may be scanty or abundant. It may even look oncocytoid, which looking like a Hertel cells. It may look squamoid, which will be orangiophilic. It may even look vacuolated. So the cytoplasm of NPTC is quite variable. And then you may have some homobodies, and then histiocytes, including multinucleated giant cells, may be found, especially in papillary thyroid carcinomas that have undergone cystic degeneration, which may be a pitfall even in histology. So this micrograph displays features of PTC. So this one, this should be easy because you have fibrovascular core at the center, which is lined by these thick multi-layered follicular cells. Even in this magnification, the cells show overlapping, crowding, overlapping of nuclei, and then nuclear grooves, and some showing pallor. So this is the higher magnification, also showing some member bodies, which are these concentric laminated calcifications. So they don't need to be there as long as you have the nuclear features. Like I said, the papillary structures and some more bodies don't need to be there. So in this micrograph, we can see that these cells, these nuclei show pallor. You have got nuclear grooves, and the arrow shows nuclear pseudo-inclusion. You have nuclear overlap and crowding. So this one, you can confidently make the diagnosis of papillary thyroid carcinoma. Similar with this one, nuclear overlap, nuclear pallor, irregular nuclear membranes. So this micrograph is just to contrast what we saw in the previous slides. So this was follicular diagnosis, follicular adenoma. So the cells lining these follicles, although in areas they look a bit crowded, they are uniform, regular nuclear contours, and the chromatin is granular. So this is just, I just put it here to help contrast this from papillary thyroid carcinoma. So this is a variant of papillary thyroid carcinoma called oncocytic variant. So you can see that it consists of Hedl cells. So, but then on top of that, you also need nuclear features of papillary thyroid carcinoma for you to call it that is papillary thyroid carcinoma. So here we have a nuclear overlap, we have nuclear pseudo-inclusions. Yeah, although the cytoplasm has that oncocytoid look, it has got this granular abundant cytoplasm, but immediately you have nuclear features of papillary thyroid carcinoma, you can confidently diagnose that. And this is another variant of papillary thyroid carcinoma, which is called tall cell variant. So you can see that the cells look tall. And if you look around, you are able to appreciate the nuclear features. There are nuclear grooves, nuclear pseudo-inclusions, nuclear overlap, crowding. So you are able to confidently make the diagnosis of papillary thyroid carcinoma. So this is just an example of poorly differentiated thyroid carcinoma. So here you have got nuclear overlap, nuclear pleomorphism, but you don't see features of PTC or papillary thyroid carcinoma. So it's just a poorly differentiated thyroid carcinoma. And then this micrograph shows anaplastic papillary thyroid carcinoma. So you can see here the cells are more larger and marked nuclear pleomorphism. So, and some multinucleated. So this is anaplastic thyroid carcinoma. And then this micrograph is also anaplastic thyroid carcinoma. But then you can see that if you don't have the history, you might think this is even a sarcoma because some of them even look spindled, bizarre, marked nuclear pleomorphism. Okay, this is an example of a medullary thyroid carcinoma. And the problem with medullary thyroid carcinoma is you have many variants, like papillary thyroid carcinoma. So yeah, in fine needle aspiration, it can be very difficult. I think it's easier if you have a micrograph like B, because in the background you have colloid, this material which amorphous acellular material. So if you have that and you also have these neoplastic cells, it may help you to clinch the diagnosis. But in most cases, I think this would end up being put in other categories, starting from category 4 to 6, depending on the variant. And on the micrograph A, yeah, this is how they say it usually looks, to have this eccentric nuclei, which are hyperchromatic. You may have even nuclear pseudo-inclusions, but you'll find that you don't have the other features of papillary thyroid carcinoma. So this was the calcitonin stain, which helped them to clinch the diagnosis. I think this is easier in places where they do cell blocks. So that is one of the advantages of cell blocks, that you are able to, from that precipitate, you can make a wax block from which you can cut sections for H&E or hematoxylin and eosin. And you can also cut sections which you can do special stains and immunohistochemistry stains. So that's the advantages, one of the advantages of having the cell blocks. So I'm almost done with my presentation. In conclusion, a holistic approach is needed in assessing thyroid nodules. Like I said, the history, the levels of thyroid stimulating hormones, ultrasound findings will help you a lot, like I said, to determine the thyroid score, and then to assess as to which lesions you are able to biopsy if they have a high thyroid score, and then also cytology, where the pathologists and technologists will be involved. And then this is important for one to assign a diagnostic category. And the advice is that one should avoid those indeterminate categories, like atypia of indeterminate significance. And if you have enough features, don't just say suspicious for malignancy. It's better to just say malignancy. So they recommend that one should avoid those indeterminate categories. Yeah, thank you. That is the end of my talk. I don't know if there are any questions on the chat box.